Good afternoon, everybody, and welcome to the webinar on the IHI Call 2 topic on cardiovascular diseases, improved prediction, prevention, diagnosis and monitoring. My name's Catherine and I'm going to be your moderator today. And before we start, I just want to share some housekeeping messages with you. So firstly, we are recording this webinar and we'll be publishing it on the IHI website. And we'll also publish the presentation slides and the participant list for those of you who agreed to be part of it. Of course, we haven't actually formally launched this call, so strictly speaking, any information on future IHI call topics is indicative and subject to change. Another important point, if you have any questions, you're welcome to send them in anytime via the chat panel. Just send them in to us and we'll get to them at the end. I will also add we have a few people online. We have Calliope, who is the scientific officer for this topic, and she's going to kick off with a presentation about IHI. We also have Kees Holving, who is going to present the topic itself. And we also have online some colleagues from the legal team, as well as Matthias Müllerborn, who is also from the topic writing team in industry. So on that, I will hand over to Calliope.
Yes, good afternoon, everybody. So I'm Calliope, the scientific project officer responsible for this topic at IHI. So as Catherine said, we will start with a few words on the IHI program as it only started recently. Then you will hear from the topic writer who will present the topic. Indeed, what's important to remember is that call 2 is a two-stage call and the pre-identified industry consortium has prepared the topic text. Then I will give you a few words on the proposal submission and evaluation, as well as some tips for interested applicants. What's important to remember is that this webinar will not go over the rules and procedures. A very detailed webinar has already taken place, and I strongly encourage you to watch it before applying, as there are a lot of new elements to consider under IHI. On top of that, there is a new webinar scheduled for Monday, the 27th of June, on how to complete the financial part of the proposal. You can register in the link provided in this slide. So, IHI, so the Innovative Health Initiative, is the new partnership in health in the EU following the end of IMI 2. It is a partnership between the EU, which is represented by the European Commission, and the healthcare industry associations represented by 5 members. COSIR, in the field of medical imaging, radiotherapy, and so on, FPA, including Vaccines Europe, Europa Bio, representing the biotechnology industry, and MedTech Europe, which is the medical technology industry. So the general objectives of IHI are to turn health research and innovation into real and tangible benefits for patients, to deliver innovations that are safe and effective, covering the entire spectrum of care, and make the health industries in Europe globally competitive. So the Strategic Research and Innovation Agenda, SRIA as we call, of IHI, details the areas IHI should work on and helps to guide IHI's decision on which ideas should be then turned into call topics. The focus of the SRIA is on cross-sectorial approaches to facilitate the creation of new products and services in healthcare, and the goal is to lay the foundations to develop safer and more effective healthcare solutions. Importantly, the research supported by the program remains at pre-competitive level, as there is an expectation for industry to work together. So before going into the topic presentation, as I mentioned earlier, this is a two-stage call. So how does it work? So the call topic has been defined by what we call the pre-identified industry consortium. You've heard me mention this already. So what it is that the industrial partners align themselves around a real and shared challenge for industry and agree to work together and commit their resources. So that's the starting point. And then what they do is try to look for ideas coming from the public sector. So they prepare the topic text, and once the topic text is approved by the IHI governing board, the topic is then launched as a call for proposals. so which is expected soon, as Catherine said. During the call for proposals, the industry consortium who contributed to the topic definition step aside, and we open the call for the applicants applying for the public funding only, forming consortia. And these are typically academics, hospitals, regulators, SMEs, patient organizations, and so on. So these applicants are the ones who will prepare what we call the short proposals for stage 1. All the submitted short proposals will undergo a competitive evaluation by an independent panel of experts, and by the end, only one best proposal will go forward to complement the industry consortium and move to stage 2. So as I said, we only take the top ranked proposal, so one consortium only, and we invite that applicant consortium to the second stage, where they will merge with the original industry consortium that prepared the topic text and work together to prepare the full proposal. Then, following a second round of evaluations, if the scores allow and if successful, the consortium will go into preparing the grant agreement and the consortium agreements, and then starting the project. So, on that note, I will give the floor to the topic writer, who will present in more detail the topics.
Thanks, Calliope. We're just sharing now, so you should be able to see that. So, Case, over to you.
All right. I hope you can all hear me. Maybe you can confirm this.
Yeah, I can hear you.
All right, good. Thank you very much, Calliope, for setting the stage and elegantly showing what the pathway is actually. What I will do in the next 15 to 20 minutes is to guide you through our way of thinking when we were writing this proposal. I do this on behalf of many of my colleagues from different companies and institutions. So thanks for your attendance here right now. My name is Kees Hoving, and I work as a senior medical officer at Novo Nordisk. Our focus will be on cardiovascular disease, and what you can see here is that our overall aim is to improve prediction, prevention, diagnosis, and monitoring. If you can give me the next slide, please. The reason why we think that is so relevant is probably also close to your heart. As we know, cardiovascular disease is one of the leading causes of morbidity and mortality worldwide. And if we then zoom into the EU, it comes with a considerable cost for a very large number of individuals. I've been a physician for a long time, and as you probably know, we currently apply a one-size-fits-all approach when it comes to treating and identifying those individuals. And yet, we are still being faced with this major challenge. And if I think about a one-size-fits-all approach, next slide, please, it's probably inappropriate. One size doesn't fit all. So next slide. If we were to redefine and get better, the overall aims would be to, one, do better risk classification, which individuals actually at risk for cardiovascular disease. To do better identification, how do we actually find those individuals? And are there novel strategies that could be exploited to identify those who are at risk over and above what we currently do in clinic? And we need a better understanding of the pathophysiological process underlying the trajectory to the event to occur. Meaning, if we think about atherosclerosis, what are the initial steps in the process? And as a consequence of a better understanding, can we actually reverse that process in order to avoid the event to occur? Meaning, we have to basically go from all the way from the basis of the disease towards a better defining of the interventions. This will result, as we probably all appreciate, into better design, development, and evaluation of novel therapies. Meaning, are the things that we are currently doing actually addressing the culprit parts of the pathophysiological process to begin with. And that, of course, serves the ultimate aim is to give the right intervention for the right individual at the right time. Not a one-size-fits-all approach, but a targeted, individualized approach. Next slide, please. We all feel, as writers of this initial plan, that can only be achieved if a large number of stakeholders are present. Not only big pharma, not only SMEs or hospitals. It should be a collaborative effort where also patients take part and other stakeholders like payers and regulators. So we would like to set the scene and really combine the multitude of databases that are already out there, whether it be in the public domain or in the private sector. And what we would like to do is to get to a sustainable data collection where we can explore new ways of leveraging existing open access databases in order to help future investigations by opening up this data collection. I think what we also need is an interchange of knowledge and experience, both from the end users, meaning patients or individuals who are at risk, really to sit down and understand what the ramifications of any intervention or any assessment that we do has on an individual basis. So I personally think that patient participation is extremely important in an essay like this. We need cross-collaboration, cross-sectorial collaboration to really address differences in the risk, whether it be based on sex, race, or cultural biases towards the disparities that we now see within healthcare delivery processes. And as such, this will really leverage the way towards personalized healthcare solutions. If I can have the next slide, please. So to set the scope of the topic, one, we would like to identify risk factors, and we would like to focus on initial drivers of disease. That being said, one could think of individuals who are on a trajectory to cardiovascular disease, but are not at the age where the event actually occurred. So this could be very well be individuals with type 1 diabetes or individuals with CKD or a genetic predisposition to atherosclerosis or heart failure. And we would like to have a continuing ranging from early development all the way into secondary prevention to understand whether if we mitigate the process itself, whether that relates to beneficial outcomes for patients. As I already mentioned, I would really like to stress the relevance of patient empowerment in collaborations as we are presenting right now. There's a lot going on with wearables and biometric data, and we have to really sit down and understand what the additive value of that is for the individual patient and what kind of cost it comes with in terms of a personal at a personal level. We also have to work on sustainable models for assessing future intervention. The way we are currently doing evaluations of currently doing evaluations of interventions is really in an RCT setting, and I would envision that this could be altered towards a more tailored approach where we really get to the right patient at the right time. So coming from a very heterogeneous clinical phenotype that we're currently seeing, if we then leverage the databases that are already out there and connect them and use currently applied analytics and methodologies, that will in the end lead to what we all would like to aim for, which is, again, the right treatment, right patient at the right time. Next slide, please. Of course, there are some examples, and I just picked two out of very recent papers that are focused on whether it be proteomics, as being seen here in the top panel from a European Heart Journal publication that was recently published, or let's say the Apple Heart study that was published in the New England very recently. It's those pieces of data that are crucial in order to redefine the landscape of CVD risk prediction and identification. And I think by leveraging all those databases and connecting them, that's the way forward. However, we need to integrate those data sets. We need to sit down with patients, regulators, and alike to really change the scheme of how we are doing things. Next slide, please. The expected outcomes, as I said, well, the ultimate aim is already depicted there, but we would like to identify novel risk factors and work on advanced predictive and prognostic models. The currently used scoring models are pretty okay, but normally have a C statistic that could be increased from 0.7 all the way upwards. We would like to see happening a situation where there's sustainable databases, and that can only be done if there is a platform for scientific dialogue on how to work with this data and how to generate this data. And supporting a CVD patient community in the EU is also an expected outcome. How can we really raise the voice of those individuals who are at risk and who are the ones who should benefit from collaborations as we are now proposing? And we would like to increase the holistic understanding across drugs, devices, data, and alike in order to drive the prevention of cardiometabolic complications. This will ultimately pave the way into a more sustainable way of doing development of novel interventions by transforming the currently applied clinical trial models into more real-world evidence models based on alterations in specific profiles in specific individuals, really getting it tailored. And that ultimately will lead to earlier treatment options and more tailored options in clinical practice. Next slide, please. The expected impact that we see is 1, increased accuracy of diagnosis and efficiency of treatment. 2, empowerment of encouraged patients. And 3, very importantly, also early diagnosis of CVD. Better understanding of mechanisms, more cost-effective strategies, and identification potentially of new care pathways. Next slide, please. What we would expect from applicants in terms of contributions are the following. 1 is access to relevant data resources, whether it be device data, intake forms, diagnostics, exploratory text for ASCVD, CKD, type 1 diabetes, heart failure, and the like. So those are specific types of focuses for us all. We plan for a data capture, storage, and sharing. So that's what we expect from the applicants. We expect understanding of early disease and generate and validate new risk models. That will be an outcome that we would really like to see happening. We would include social and ethical regulatory aspects in collaboration with stakeholders with a specific interest in that. And as we are living in an economic world, and I started off by showing what the actual economic burden is that comes with CVD, we would really like to see economic models happening based on the data that is being generated to see whether we are indeed making a more cost-effective model for treating individuals at risk for CVD. It would ultimately lead into a decision tool for physicians and an integrated PROM model, and explore possibilities for novel methods of clinical trial conduct and development pathways. Next slide. The overall funding, as was being stated, is over 11 million euros in kind as of now. And what we will bring as the industry partners to the consortium is largely data from clinical trials and biobank data, real-world evidence data, wearables, and the like. We will bring expertise, medical expertise in bioinformatics, but also data science, public health, and also experience from a regulatory pathway from our angle. and early identification from wearables. We bring in technology such as wearable devices and mobile technology, and we are aiming to identify the hurdles and solutions toward the right treatment for the right patient at the right time. The partners are depicted below, and as can be appreciated, over 11 million euros have now been raised already. Next slide, please. The budget from IHI is up to somewhat more than 11 million euros. An indicative contribution from the industry partners is almost 9, and the financial contribution from a contributing partner is approximately, from contributing partners, sorry, is somewhat over 2 million. Indicative in-kind contributions from industry partners may include in-kind contributions to additional activities as well. So this is being put into the budget as it is right now. Next slide, please. The duration of this whole collaboration is 48 months, and that probably precludes us from doing prospective studies where we collect data. So we are really embarking on a readily available or in the very near future to be collected data. And we can, as a consortium with the contributing partners, agree on a different duration when submitting the full proposal. Next slide. I would like to thank you for your attention, and I would really look forward to hearing from you in the future. If there's any question, I'm happy to take them. And if it's related to the process itself, please reach out to Calliope, who you've just heard about specifics when it comes to that trajectory. Thank you for the attention, and happy to take the questions.
Thank you very much, Kees. Calliope actually has a couple more slides, which she'll present in a moment, just to give a few more tips to the potential applicants. But I will just draw the attention of the webinar participants to this sentence on this slide that you can see here. If you have any questions about the call, do not send them directly to the industry consortium, to Kees or Matthias or any of the others. All questions about this topic should come to us. We're in a slightly potentially confusing time now, because at IHI we are of course launching 2 calls in parallel, and the other call is a single stage call, and now we're telling you everywhere you need to reach out to industry and include them in your consortium. This is a 2-stage call. As Calliope explained, there is a pre-formed industry consortium, which you've just seen there. They are already there, so you should not contact them, because you could cause problems with conflicts of interest and things when it comes to the evaluation. So any questions, send them to us. So now I'm going to hand back over to Calliope.
Yes, thank you, Catherine, and thank you, Kees, for the presentation. To continue on what Catherine said, of course, yes, you can email us your questions regarding this topic, but of course, during this webinar, you also have the opportunity to raise questions, because this is pretty much the only interaction you will have with the topic writers. So please use the chat function if you have any questions for our topic writers or for the IHI office. I would like to now go over some slides regarding the proposal submission and evaluation. So, as mentioned, applicants forming the public side of the consortium will now have to prepare the short proposal for stage 1 of a 2-stage call. To repeat, we expect to receive a few applications, a few short proposals as a reply to this call, and following the evaluation, only one will be invited to merge with the industry consortium, and then if accepted, go forward to a granting phase. So for the short proposals, here are the elements that need to be prepared and submitted. So it's the proposal template, which has part A, B, and some annexes. So part A is usually through the tool in the funding and tenders portal and includes all the administrative data. Part B is the narrative part that includes sections of excellence, impact, and implementation. And of note, for the short proposals, the page limit is 20 pages. So the proposal template is actually available or will become available upon call launch, and a version of it includes instructions under each section. So when preparing your proposals, we invite you to read it very carefully. For the short proposal, an annex will also be requested in order to be able to submit your proposal, which is the participant type annex. So applicants are invited to list all their participants or beneficiaries and which type they belong to. Are they an SME? Are they a hospital? Are they a patient association? So this is the annex, and it will also be provided, the template will also be provided in the submission environment. So maybe to tell you, since the proposal template has these three sections, excellence, impact, and implementation, it's quite logic that, of course, the evaluation criteria will follow the same approach. So the criteria listed here, and this is the criteria that the independent panel of experts will use to evaluate your proposal. So you can have a look at the details of the criteria later, but they cover excellence, impact, and implementation. Importantly, just to tell you the thresholds, in order to pass, you have to have at least 3 out of 5 for each criterion, but an overall of 10 out of 15. So, and of course, to go to stage 2, you need to be the best scored ones. It's not enough just to pass, you need to also score the highest. So there, yeah. So some tips for you. I can't repeat this enough. Please read all call relevant materials, especially the topic text. This is the key document against which the evaluation of your proposal will be done. So when preparing as well your application, although the industry is yet to join and will only join should you be successful at stage 2, already start thinking of the public-private partnership aspects. Why is IHI the right framework for this project that you are proposing? It's important to see how this public-private element is considered in your proposal and will be important for its success. Please ensure that all information requested in the call text and template, as I said, it has some instructions, is provided to allow the evaluation experts to assess your proposal against the criteria. As well, please consider early on and plan for the potential regulatory impact of results that your project could achieve. Finally, a slide on finding project partners. So, of course, you will need to build a consortium or join an existing consortium. So please don't hesitate to network with your contacts, to network with the webinar participants, use the tools available to you via the funding and tenders portal, get in touch with the IHI contact point, and network on social media. This is it from me. Thank you, and we're happy to take questions.
Thank you very much, Calliope. So we do have a few questions in, and as Calliope mentioned, this is really your only opportunity to get the information directly from the topic writers. I will add as well, in addition to the topic writers, we also have online a couple of members of the IHI legal team, Desmond and Domenico, in case there are any questions that are more relevant for them as well. So in the first question, and I think this came in before you answered it in your presentation, how many projects will be financed under this call? The answer is 1.
Yes.
And that was explained. Another nice simple question, will the recording and slides be available? Yes, they will be. We'll publish them online. And the presentations during the brokerage event will also be published. My colleague Tom is, as we speak, overheating the IHI servers, grappling with the large video files there, but they will all be online. And another important thing from the brokerage event in terms of finding partners, there are a few people who made pitches on this topic as well. So that's another opportunity for you to find partners there. Now, there's a question which is a little bit for the office, a little bit for the industry side. If the industry consortium is already formed, Does that mean that the call is not open to industry anymore, or did I misunderstand?
So in principle, you are correct. So the industry has preformed the consortium and will contribute to the project in kind. However, when we talk of industry, of course, an SME and so on could be considered also belonging to the industrial sector. So it all depends on the cap, if it's the size of the company and so on, and if they are applying for funding or not. So this would be my part of the answer. That is not like a stage one situation, a single stage situation where you're expected to bring in industry within kind. It's already there for you. But on the other side, of course, in case, correct me if I'm wrong, but if larger companies are interested to join in the in-kind part, they will do it via a different route and not via applying through the with a short proposal.
Yeah, I think you're completely right, and I think my direct Matthias can really speak to this. He has a long-standing history when it comes to this type of processes. I would encourage everyone to join. I think this is a major task in front of us, and it would be great if more partners could work with us, as long as we're all dedicated to actually achieve the numbers of goals that have been already predefined. But Matthias, maybe you can speak to this for a minute.
No, but it's exactly as you say. So we are open also for any other industrial partners, either on the in-kind side or on the applicant side. So of course on the applicant side there's some limits, as you mentioned, Calliope, but we are open to new partners. So we have been very open there. And there's probably also a question later on the 45%, which you probably will address as well. So of course this is already given, as we have already 50% from in terms of funding. So that's already there. But of course, any additional contribution would be just appreciated, right?
So maybe to mention, so we have this question as to whether the winning consortium needs to fulfill the rule of 45% contribution, or when the industry is joining at the second stage, the 45% contribution is then fulfilled. No, it's the second part. So basically, in the short proposal, you don't need to bring a 45% in kind. The idea is that the final project that will result will have automatically this 45% in kind, or 50% in this case, because industry is already committing half the budget. So as a short proposal, you don't need to get this contribution.
Could I interject just very briefly on this?
Yes, please. Desmond, our legal officer.
Hi, everyone. Just a quick comment. I would support completely what Calliope is saying, that the 45% obviously will be brought in by the pre-identified industry consortium in stage 2, but it will need to be evident to the experts that the 45%, this industry contribution, has been thought about at stage 1 in the first stage evaluation with the applicant consortia. So it won't be possible to just ignore it completely. There should be some thinking about how this in-kind contribution will actually be used, and this should be referenced in the actual short proposal.
Thank you, Desmond, and you're right, and it goes with what I said. It goes well with what I said earlier, that to start thinking of the public-private partnership element also when preparing your short proposal, because there is a reason why the industry has already described the contributions they wish to bring on board and why this topic is prepared under a program such as IHI. So please consider this when preparing your short proposal.
And there are a lot of clues both in the slides and in the topic text. There are sections on what the industry consortium will bring and what is expected from the applicant consortium. So it comes back to reading the documents. And in terms of the documents, I will just add, I mean, this is obviously, these are the first calls of IHI, and I can tell you that in the next few days, and certainly before the call launch, a lot of documentation is going to hit the IHI website. It may look overwhelming, obviously including all the final topic texts and everything, but there's also going to be a guide for applicants and all the details of the evaluation criteria, the proposal templates, they will all be there. And all of it together will help you to put together a good proposal. Next question, will the final call, I guess, topic text include the work package list?
So as opposed to maybe your experience maybe with IMI2, no, there will not be a work package list. And the answer is that, you know, upon you can make a proposal even in the section of implementation in the short proposal template. There is no expectation to develop this into detail. But the idea is that if you win, if you are the highest score proposal and you join industry, you will be able to better define together the work packages and give more flexibility and opportunity for this public-private partnership to work.
Okay. Next question is for Kees. You mentioned, given the 48 months duration of the project, the generation of prospective data is not likely. How about generating a new, for example, omics data from patient samples which have already been collected before the project?
Yeah, that's a very good point, and thank you, Krista, for raising this question. I must be more explicit here. It seemed that I was very explicit, but it's not the case. What I want to say is, we are not thinking of doing randomized controlled trials. That is important. That is important to stress, that within a 48-month period, at least our experience as an industry, that's impossible to do. The thing you propose is actually a very good one. If there's already data samples out there, and then to join with the team and see with your collaborators to see what can be done to leverage most out of it, that is actually exactly what we would like to do. So the way forward you are proposing here is exactly in line with what we as partners have been thinking about.
Okay, thank you. Another question now for you, Kees. Can you talk a bit more about the monitoring aspect of the call? It seems to be a bit focused on pre-diagnosis. Is this the case?
No, it's not the case, and maybe I should also be more explicit about this. What we as industry partners bring to the table is actually intervention trials, most of the time in a secondary prevention setting. We would like to see the whole scope of the trajectory of athero. So it's by no means that we're not going to focus on those who already had the disease, where we try to mitigate that process and want to learn about the profiles of change within those individuals responding to the drugs that we have investigated in RCTs. So if that was the impression that I left, it's indeed not the case. We are spanning all the way far into secondary prevention, and you could even look at second and third events, for example, to occur. So it allows for the complete trajectory of atherosclerosis from the beginning all the way into to the interventions. So thanks for raising this, Francisco. Yeah.
Okay, thank you. And now a question for us internally. What is the expected deadline for submission?
So it's usually 3 months after the call is launched. So I would say end of September, exact dates to be confirmed upon the launch.
Okay. And now another question for the topic writers. Are prospective studies entirely out of the question?
No, it's not completely out of the question. However, I would like to stress that, again, in the concept of doing a prospective study, if that is the prospective setting where you embark on numbers of events that arise during the follow-up, we deem that to be highly unlikely to be met in a setting of a time frame of 8 months, and that's the reason why we raised it. I could definitely see that prospective studies can be done, and as was being stated before, doing some form of prospective studies with already existing the biobank samples makes complete sense. Yeah, absolutely.
Okay, thank you. Another question which I'm going to direct to Desmond. Can Swiss entities also participate even without funding?
Okay. Yes. All right. So let me address this in 2 separate parts, just for clarity. First things first. The Swiss entities, because there's a difference between eligibility in participation and eligibility for funding. So at the moment, Swiss entities don't get funding from IHI, but I'll come back to that in a second. But Swiss entities are very, very welcome to participate in IHI actions. they made a very valuable contribution to IMI2 and IMI1, and it makes complete sense that they come in and participate in IHI. So this is clear. In relation to the funding, as I said, they can't, because they're not an associated country and they're not associated to Horizon Europe, they cannot receive funding for IHI actions through IHI. However, they are, as we understand it, they're more than eligible to get funding from the actual Swiss government when they participate in IHI actions. And indeed, the IHI legal team had a fascinating conversation with a gentleman from Switzerland at the brokerage event, and this was apparently reflected in their domestic law. So there is a facility there for them to receive funding from the Swiss government themselves if they participate in IHI actions. So my answer in both cases would be yes, you're more than welcome to participate, and B, you can also receive funding, just not from IHI.
Thank you very much. Another very practical question, more for us in the office. For phase 2, the full proposal needs to be prepared by the industry consortium and the applicant consortium. What will happen if the full proposal is not approved by IHI?
So nothing. So the full proposal is, if it doesn't score high enough against the criteria, then it will not pass and will not receive funding, and the process stops there. There's no going back to another proposal and so on. So that's it.
Yeah, this is an important point to emphasize. At stage 2, it's obviously not competitive anymore in the sense that there is only one proposal, but there are still those thresholds, and if the proposal doesn't meet them, it will not get through. So don't relax. If you get through to stage 2, don't rest on your laurels and relax. You need to do a good job at stage 2 as well. Next question. As patient involvement is crucial, why does the single industry consortium not reach out to European patient initiatives instead of all the academic consortia? Calliope.
Look, I'll give a first go and then you can complement. But of course, the idea is that is the pre-identified industry consortium that prepares the topic text and what they expect. And reaching out to specific European initiatives would maybe create a bias towards certain projects or initiatives and so on. So the idea is to allow the public side, and I see here you mentioned academic, but it's more of the public side, to do this outreach as they see fit and allow every potential patient group or initiative to be on board. That's why we avoid mentioning initiatives by name and so on in the topic text. So then, of course, our industry colleagues can answer as well on their side how they feel about this, but this would be my take.
No, Calliope, I'm fully aligned with that. And as a matter of fact, there is already a connection. And the reason why I stress the importance of also having patient initiatives on board is really that we would like to see what the impact is on the individual patient, who is, in the end, the one who should benefit from an initiative like this. I think, in all fairness, it's also good to realize that, Calliope, you are in connection with many of the interested stakeholders. So if you are an academic partner or another stakeholder and you don't have the direct connection as of now, please reach out to the IHI office, because they could liaise you with potential partners that have expressed interest as well.
I mean, I think as well it's worth mentioning, I mean, in terms of the makeup of the applicant consortia, if you go back and look when we publish it at Calliope's slide on the call process, you will see that at stage 1, we do fully expect the applicant consortia to include not just academics, but also small and medium-sized enterprises, potentially regulators, and of course, patient organizations. So if you are a coordinator putting together an applicant consortium, it's on you to make sure that you are that you have the expertise in terms of the organization types, and obviously patients' expertise is very specific and unique, and it needs to be there. It's on you to make sure it's in there. And it's certainly, I would add as well, it's not for the industry consortium to reach out, because as we said earlier, that would be a conflict of interest as well. So.
Yeah, and then maybe on what Case said, just to mention that, okay, we will not direct you to a specific association or anything like that, but as we said earlier, the events that we schedule, these webinar and so on, will give you contacts or potential contacts that you can reach out to. So these are good tools, as I put in the tips for applicants slide, for you to be able to identify potential potential beneficiaries or co-participants.
Okay, thank you. So the next question is a little math test for us. For clarity, the overall budget to be awarded to the winning project will be 11.1 plus 8.9 plus 2.2 equals 22.2. Can you confirm?
So let me maybe clarify. The industry consortium, the budget that they indicate that they will bring forward, which is 11.1 million, is in kind, right? So it's not necessarily, except for maybe a part that might be direct cash contribution, financial contribution. What they will bring forward is expertise and resources. So it will not be for the public side to spend as such. What if you are planning to apply for the short proposal now for the stage 1? Yes, there is a budget available of 11.1 million for the public side, and then the cost of the project, or together with the in-kind, will reach at 22.2. But I don't know if my legal colleagues want to add something on this.
No, I mean, I think you've captured the essence of it. What we would say is it's very clear that the industry consortium, and it's been mentioned earlier in the slides, that is in kind, which is actually being brought. It's primarily know-how, availability of resources, that kind of thing. There may be a cash component. I don't have those figures to hand, but in terms of funding, that's the IHI component, which is basically coming in. That's, for want of a better term, the actual cash that is available, and it's probably better off keeping that separation in your heads right from the very start.
Yeah, so when considering budget allocations, consider the availability of the 11.1 million.
There's a question asking when the final topic text will be published. So we're expecting to launch the call next week, and that's when all the documentation and all the details of the deadlines will be available for you.
And as I mentioned, the short proposal deadline is usually around 3 months after call launch.
Yeah. Okay, question now on asking, does the consortium have to answer every point of the expected outcomes?
I would say in short, yes, but I invite Case to complement if necessary.
No, I think that's according to the rules and regulations. One cannot just pick one and just focus on that. The depth and the width of what we are actually going to do is largely based on what I would say, and Calliope, correct me if I'm wrong, what is agreed upon once the consortium is being formed, meaning that there's still room to operate in terms of how to really focus on this. There is, as you know, this is a core text. It doesn't show work packages whatsoever. That is still to be defined. So it's also up to you as potential participants to shape that agenda, meaning that it's not only the consortium that has written the initial report that is driving the agenda or the outcome. But that being said, we aim to have answers, whether it be very elaborate or somewhat less, to all the questions that were being raised, because we all feel that these are major roadblocks towards the wide application of good healthcare for individuals.
Okay, another question now on the industry contribution. Is there a more specific list of what the industry consortium will be contributing? The slide displays high-level information. Trial data, for instance, will there be a list or description of the trials to be made public?
Maybe, Case, before, maybe to give set a bit of the scene. The industry contribution is now presented in such way, but of course, consider that it will become a lot more tangible and specific upon the formation of the full proposal. So I guess some of the industry contribution will also depend on what the public side will put forward. But on a more specific answer, Case, please feel free to comment.
No, Calliope, that's exactly what I would like to say. I mean, being stated before, it takes two to tango. So what we can bring is indeed data from clinical trials, and so do our colleagues from other large pharma, and so are the smaller companies that have signed up to participate as well. So everyone brings, and one could think of what the core competences of those companies are, their expertise, their data to the table. So there is no list as of yet that I could disclose saying, you know, we're going to deliver data sets on X, Y, or Z number of individuals and with various diseases. But one could, of course, think when you look at the partners, what types of data will be delivered in this IHI project.
Okay, thank you. Next question. Can you provide on the IHI website an overview of the initiatives of groups that will apply for this call? This way experts can join a writing group of interest. The short answer is no. I mean, this is a competitive call for proposals. What we have done is, I mean, we set up the brokerage event. And if you go to the website there, the people who have indicated their interest in this topic, you can find them. And all of that is via the event section. We will also publish the list of participants in this webinar for people who agreed to be part of it. And again, you can go there and get an idea. But, you know, you do need to do the legwork. And I mean, of course, no, although we often know some of the groups that are putting together a consortium in response to a call, there is no obligation for a group to let us know that they're building a consortium. So you do need to do the legwork in terms of, you know, finding a consortium, joining it and things like that. Next question, what is the purpose of the evaluation at the end of phase 2 if only one project gets through? Well, as we said earlier, there is still an evaluation and there are thresholds. So yes, it's a quality check.
Exactly. And don't forget that in the short proposal, there is no integration of industry. So we must have a quality check that this integration is working properly and that what is proposed is good. So I think it's necessary to have this evaluation, even if only one project is evaluated.
Okay, next question. This is for the topic writers again. Should the projects be focused on atherosclerosis and heart failure, or can the cardiovascular conditions be taken more broadly, considering the title of the call text?
The conditions can be taken more broadly. Again, we are inclusive when it comes to ideas that would serve the purpose of what we have defined. So if you as a potential collaborator think that we should take yet also another angle, please do so, because that could be very complementary. This is what we came up with. And again, we would like to welcome you to also provide your insights to really leverage the full power of the consortium.
Maybe to add something, Case, here is that, of course, these are mentioned in the topic texts. And of course, the experts that will evaluate the proposal will also take this into consideration. So if you take this more broadly and consider other elements, it has to be very clear, as you know, the experts and the industry will also not interact. What the experts will evaluate your proposal against will be the topic text. So I would be a bit careful there, but yes, as you said, if it's a bit of broadening, of course, but since these two are mentioned in the topic text, some due consideration should be given.
Thanks for the clarification, Calliope.
Yeah, the topic text is your Bible when you're replying. Next question, and it's a little bit related. Is the call more focused on CAD or all kinds of cardiometabolic diseases? Is using multi-omics analysis to identify inflammatory, metabolic, epigenetic, or genetic signature is a focus?
Yeah, that is a focus, as long as it serves the purpose of what is being stated in the core text. Atherosclerosis is one, but as you have probably seen, there's also a heart failure mentioned, and we know, for example, and that's our angle from the company that I work with, that there's indeed cardiometabolic disorders that ultimately drive individuals towards the trajectory of heart failure. So understanding that trajectory is in scope according to how I interpret the core text. Yeah.
Okay, another question for you on the topic team. You mentioned CKD, type 1 diabetes, HF, ASCVD. Does it mean that healthy controls and population-based cohort studies should not be included in the proposal?
Oh, I love this question, and thanks for David to raise this point. I would say absolutely. If we want to understand what a abnormal trajectory is, we better also understand what the normal perspective is. So as a comparator, we absolutely need individuals that have no disease or have not developed disease over a course or over a predefined course frame. So I would be actually keen to have healthy controls as a comparator in a setting like this in order to understand what the deviation of normal actually is.
Okay, thank you. Next question. In the view of the healthcare industry, what would be the benefits of this initiative for the academic stakeholder consortium?
I assume this is a question for me from Helen.
I think so.
Yeah, no, I think there is a huge benefit. One, access to individuals and colleagues who are working on similar types of questions from a different angle. It allows for a huge interactive intellectual platform and probably also very importantly, access to methodologies and evaluation forms that you might not have in an academic setting. I just showed some papers. I could pick many of them, probably from many of the individuals who are on the line right now. What we can bring to the table is actually what an intervention does, and I think from a clinical setting, that is crucially important. So what we tend to observe is again, very focused intervention or evaluation in a specific setting, not necessarily the intervention where we control all the aspects, meaning a placebo-controlled randomized trial. So I think there's a multitude of benefits that an initiative like this could bring to an academic. A disclaimer or disclosure here, I used to work as an academic and have been part of initiatives like these. And it has always been extremely, it was always a very, very great pleasure to work in a setting like this for me as an academic in the old days. So I think we can bring a lot to the table and we can learn from each other in a setting like this.
I'll just add as well that on our side, when we've spoken to people from IMI projects and we asked them what are the biggest benefits, the networking element, as you say, the opportunity to learn from people from different stakeholder groups with different experience to yours, different ways of working. That's usually the first thing people say when we ask them what were the best things about being in a project. It's a huge benefit. Next question, and this is more for us. When will the winning public consortium be announced?
So again, as we said, the timelines are still a bit tentative, but the expectation is that the outcome of the evaluation will become available end of November.
But that's the stage 1 evaluation.
Yes, yeah, because it's the public consortium. So from that point on, we will expect that the public and private consortium will merge to prepare the full proposal.
But we will only publish the information once the actual project, once the stage 2 evaluation has happened, assuming it's successful, of course, that the project passes, then the grant agreement will have to be signed. And it's only then that we'll actually publish information on the final consortium. So there's quite a way.
It's not so much of an announcement, but more that the winning public consortium will be informed that they are top ranked.
Yeah.
And the rest that they have not passed.
Okay, another question for you, Kees. Can you clarify the role of wearables in this call? It seems like using them within the project is not an option given the timelines. Is it limited to using databases collected with wearables?
That's a tough one, I would say. I think it's not mutual exclusive. There is data, and we expect data from already obtained assessments in different types of population, whether it be healthy controls, whether it be specific patient populations. a prospective or collection of data could very well be part of one of the work packages. And you can already sense that I'm a little sensitive to be really definite about this, because again, this is work that has to be get to full fruition once a collaboration is formed. But I could definitely see that both are an option, again showing that there is where the endpoint is when I think about prospective studies, cannot be a clinical event to occur, but one could think of other projects that are more prospective, where wearables could be used where the endpoint is somewhat different, probably linked to data generated in other work packages or focus groups.
Okay, thank you. Another question for you now. Considering the openness of the call, are there things that you expect not to be part of these projects in relation to RCTs?
Well, I can only speak for my own company. We embrace transparency and openness, and I would definitely think that the partners would think alike, and I cannot think of things that you expect not to be part of these projects. Well, anything, and Calliope, maybe you can speak to this, how this works with IP. This is not in the competitive space. So anything that is really related to novel target and identification is out of scope for us when we are already working on that from a different angle. So Calliope or Matthias, maybe you can speak to this, having you both having more experience in this. But I would be very open and willing to share a lot.
So maybe I'll involve also the legal team here, but on my side, what I would like to say, not to be part in the openness, is for the applicants to consider the available budget and duration. So that would be my main contribution to this question. So there are things that would take a long time and things that would cost a lot. And the experts, when evaluating, will check whether what you said you will do is feasible within the time frame and budget allocated. But regarding the IP and so on, yes, indeed, this is a pre-competitive space in order for the companies to collaborate together, of course. But what is anything else that the legal team wants to add?
You're muted, Desmond.
Just as a lawyer, when we talk about RCTs, we're talking about randomized clinical trials, right?
Yeah.
Yes.
Okay. just to make sure. No, I would say, as the lawyer in the room, I would say, I mean, from an IP or from an intellectual property rights perspective, I mean, the intellectual property rules for IHI are quite robust. We have the hard rules there in the actual grant agreement, and then you have a certain degree of flexibility in the consortium agreement as well. So, I mean, I think from the legal basis, it can accommodate whatever they want to actually put in. I think the much more relevant criteria is that which has been brought in by Calliope, which is basically, and Keys, which is basically just like, you know, how long you actually have to do and the kind of stuff that you'll be able to do within the time frame of the project. And obviously, you know, this is going to be looked at the evaluation stage when you list what you want to do, and the experts are going to say, well, is this actually achievable within the time frame? I think that's one of the key points. So I think the legal basis is less of an issue here, and it's just the time parameters and the mechanics that are going to really determine what's put in.
And maybe Matthias, as Kay said, you may have something to add on this.
Yeah, but I agree with what was said actually, and the thing that the case I think refers to is that we have experience with projects where we got into conflicts of interest. You know, if you have let's say there are startups that are trying out their new algorithms or devices, and then they have to be aware of that. This is an open. So we are expected to publish things, and people have access to the results according to the rules, and so they should really look into the rules of IP to make sure that we don't run into that problem. And so product development is certainly not something we want to do as part of these projects. So that's usually a little bit tricky then. And the same thing comes a little bit also to, for example, using devices that are not already on the market or CE marked or something like that. It's very difficult to bring them into projects like this because again, the whole procedure around getting approvals and so on around this will be longer than the duration of the project. So it's not a playground for a lot of new technologies in that sense. Yeah.
Okay, thank you. Maybe we can move to the next question, which is another one for the topic writers. We are collecting prospective imaging and omics data on a CAD cohort. How can we deal with informed consent and DLSI issues?
First of all, that is great news that you are doing a study like that, because that is completely aligned with the aims of this. With regards to informed consent, I've participated in quite a number of international studies where we used individual data points. And what I've learned is by participating and leading that project is that, again, there are quite some overarching rules, but please be aware that you also comply with your own local legal IRB prerequisites. So it is not as much of a problem as long as it's being taken care of in the right way. And if the informed consent doesn't allow you sharing either anonymized data or depersonalized data, then I would not encourage you to move on, because then you have to basically reconsent everybody. However, also being worth mentioning here is that there is quite a number of companies that are already working on algorithms to anonymize individuals in a very structured way, and maybe Matthias, you can speak with that, speak about that. You have had some experience with that in previous conversations. You mentioned this.
Yes, yeah. So not much said, I think. Yes, correct.
Okay, the next question. If not wearables, what about data from in vitro or in silico models, or is this too preliminary towards the goals of IHI?
That is rather a broad question, I would say. And in silico models and in vitro data could definitely serve the purpose of the overall aim. So it's really dependent on how you would envision that data would serve the purpose. So again, rather vague, but I would not exclude this based on the fact that it's in silico or in vitro. When it serves the purpose of the IHI, I would encourage you to also implement that. Again, following the lines and outline that was being proposed, as Calliope already mentioned.
Yeah, so maybe in terms of preparing a proposal, you have to talk of impact, of course, and the impact that is proposed by the industry in the topic text is aligned with the impact that IHI wants to achieve. So really, if these models work, please do consider how, for the topic, do consider the journey of the impact, and both with regards to what is in the topic text, but also what the IHI mission is.
Okay, and now moving on to what is currently the last question. So if you have any other questions, please get typing. Do you expect to create a new data repository for this project, or could the data be available in existing databases?
This I will leave over to Matthias, who has way more experience in how to capture data. There has been quite some experience in this field.
So we haven't really excluded any models. So this could be a federated system where it's existing data and we just do the federation. It doesn't have to be a new depository. But it could also be that. So that we leave that actually open to the applicant consortium to come with a plan on how to do that in the best way.
Okay, thank you very much. For the moment, that is the last question. So I will just remind you, obviously IHI is new. So if you, and even if you're familiar with Horizon Europe, or if you were familiar with IMI2, there are some significant differences, and I would really encourage you to watch the Rules and Procedures webinar. The recording and slides are already on our website. If I'm not mistaken, the budget table is not applicable for stage 1 of 2-stage calls. Am I correct?
Yes, Catherine, you are correct. There is no need to do the breakdown.
But it will be needed at stage 2. So, you know, if you're obviously hoping to win the first round here and get through, then it might well be worth as well checking out the webinar, which we will have next Monday on, which is really going to focus on the budget table, how to fill it in, the different types of industry contribution. It will also be useful more broadly if you're interested in applying for other IHI funding in the future. So that one, I would strongly recommend you have a look at that. And of course, keep your eyes on the website, because we will be launching the call shortly, and then you will have the final official information on the topics, all the details, how to apply, the guide for applicants. And if you have any questions after today, as we said, please don't contact Kees or Matthias. Contact us at the IHI office. We're always happy to help you, especially because IHI is as new to us as it is to most of you as well. So we're also learning, and we also always want to improve the information and guidance we give to applicants. So if something isn't clear, do get in touch with us. So I don't see any more questions. So I will say thank you very much to Calliope and Kees for your presentations and for answering your questions. Also to Matthias and Desmond for answering questions as well. Thank you to all of you for your interest in IHI and in this topic, and good luck with your proposals. Thank you, everybody.
Thank you very much.
Thank you.
Bye.